Aloha, Hawaii. It's time for the Vein Clinics of Hawaii radio show. Their team's approach to diagnosing problems and developing solutions and treatment plans are beyond compare. So let's get started with your host of the show, Mike Buck, and medical director, Dr. Randall Juliff of the Vein Clinics of Hawaii.
You know, he sounds so happy, this announcer does. And sometimes we talk about really happy things, and sometimes we don't. But he's got this level of enthusiasm that gets me going. Welcome to the program. Vein Clinics of Hawaii on 4 of our islands, on the Big Island and in Maui and Kauai and here on Oahu, treat veins and a lot of other things. The medical director you just heard, Dr. Randall Juliff, is here, and we do a program. Some of you may be with us a program or two ago when we had a program called the Most Frequently Asked Questions, the FAQs, if you will. And one of them was something that I'd never heard of. And when Doctor explained it to me, I thought, maybe we can twist his arm a little bit and do a whole show about this. It's called Pelvic Congestion Syndrome. And I'm very relieved to know that I can't get this syndrome. But because I'm a man. Well, that's the hope anyway. And I think that it would be a real funny deal if a man did get this. Maybe it's possible, but maybe not. Doc, that's kind of a negative, introduction to the show. But I think that, first of all, women go through a lot, having a baby. And this is one of these things that may or may not affect women. What is this? First of all, what is a pelvic congestion syndrome?
Well, we, as you mentioned, we talked about frequently asked questions. And one of the questions that we get very, very often is, are there other parts of the body that can develop varicose veins? Mm-hmm. Obviously the most common place is the legs, and that's what the majority of our patients come in with. But you can actually develop something that is very, very similar to a varicose vein in this situation. In the pelvic area. Yeah, in the pelvic area.
Yeah, so most of the time you've heard us talk about this, and most of you that are, a patient, or most of you that have had varicose veins, it's usually lower leg. And this pelvic area is kind of a couple of feet away from that.
It is, yeah.
And so, however, is it because everything lines up like it does at the bottom? So it is, wait a minute, here's the question. Because I don't know about the pelvis like you do, I'm guessing that the fetus and the embryo and the baby that's being born is at the end of a trail. That stuff is feeding that, so it doesn't come from somewhere else. There's a special system for that.
Yeah, I think what you're getting at is the fact that we get varicose veins in the legs because of the fact that since we stand upright most of our life, most of the pressure that go through the through the venous circulation to our body and extremities, the greatest amount of pressure is down there. And there is a similar situation because the veins in the abdomen, they start the veins that supply the pelvic organs, they actually arise at a site higher in the abdomen, and so so
it has a downward flow like our guys, the legs do.
Yeah. Okay. And the blood flow should be going one way, and instead it's going another. Yeah. But and this is the other reason that I wanted to talk about this today is because many people haven't heard about it.
Yeah, I was for sure. I thought I knew everything. Of course, my mother's been saying that since I was a little child. I don't know everything, but I'm working on it. I'm learning a little bit every day from you.
That's the best way to do it.
Yeah.
But the typical symptom of a lady who might have pelvic congestion syndrome is pain, and pain can be caused from a lot of different reasons. And pelvic congestion syndrome is just one of them, probably a lesser common form of pelvic pain, but still one of those things. And it hasn't been very well, I guess, delineated and diagnosed, especially in the past. And I think in more recent years, number one, we understand a little bit more about it, and our diagnostic modalities have kind of gotten to the point where, from a quality standpoint, we can really make that diagnosis. But, pelvic pain is a big problem. 10 to 15% of outpatient gynecologic visits are for pelvic pain.
Okay,
so it's very, very common.
Yeah, let's assume that for the topic of conversation now, we're talking about some woman that's pregnant. that there's a womb and this fetus is getting the nutrients in the blood and everything. Does the system function when there is not a pregnancy?
Yeah, and actually this is a problem more so when women are not pregnant.
See, I would have thought the opposite. That's why I'm glad. So those of you that are not pregnant, you ladies, you better listen because, I was thinking there's just so much going on during the pregnancy that a lot of stuff can happen, and that was one of the things that could.
Well, the result of or the changes of the female body that occur during pregnancy, those are what ultimately do lead to this type of problem.
Okay. But see, when you said pain, I didn't think that area would be possible to have pain if the patient wasn't pregnant. But no, that's not the truth. I mean, there's plenty of pain when they're pregnant, all kinds of pain, right?
Absolutely. Absolutely. Yeah. But yeah, I mean, this is obviously abnormal pain. And it's, many women have discomfort in the lower abdomen and pelvis. That cycles with their menstrual cycle. Okay. That's pretty common. Mm-hmm. This pain, however, is a little different. It's more chronic. It's there all the time. And, one of the definitions that we sort of look at is that if a lady is complaining of pain in the pelvis and lower abdomen for a period of 6 months that is not necessarily related to her menstrual cycle, then that is something to be concerned about.
If she goes to her doctor and has this pain and the doctor does the examination, or OBGYN, will an X-ray reveal what's going on with the veins at all? Because I was thinking, no, that you have to use ultrasound or some other thing.
Yeah, right. It depends. There's a number of different, diagnostic kind of things that we might do. Ultrasound is one of them, right. And most ladies, when they come to the doctor with pelvic or abdominal pain, one of the first things we do is ultrasound. Gotcha. But ultrasound is not necessarily the best test for the diagnosis of pelvic congestion syndrome. But other symptoms that ladies should look for aside from pelvic pain is something that we call dysuria.
This is to do with urination.
Mm-hmm. Yeah. Pain when you urinate. Back pain.
My aching back.
Oh, yeah.
Yeah, you bet. Sure. Yeah.
Something called dyspareunia, which this syndrome can create pain during intercourse. Mm-hmm. So that's another one of the hallmark sort of signs of this problem. Gastrointestinal type symptoms, bloating and symptoms that might be similar to irritable bowel. Mm-hmm. And that's why it has always been a little difficult to diagnose definitively, because it's the pain that you have with pelvic congestion syndrome can be very similar to a whole host of things.
I was going to guess. You named a bunch of symptoms, which we've talked about before in other things. Is it probable that the person has multiple symptoms?
Causes?
Or
symptoms. Multiple symptoms?
Yeah. In other words, this is sore, that's sore. It's painful when I urinate, when I have sex. I mean,
definitely.
What's going on here?
Oh, yeah. And that's why you kind of have to put all the pieces together and try to come up with what's going on. Now, the other thing that can be a sign is that along with this, women will sometimes and not infrequently also have venous problems of the legs.
Okay.
So, that can be also a sign that sort of tips us off. Gee, somebody comes in with complaints of pelvic pain and the other things, and they also have a bunch of varicose veins in their legs. They often go hand in hand, and it can be a tip to the diagnosis.
What about this? Let's say that we know that varicose veins or venous conditions usually come with age. And obviously, if somebody is coming that doesn't have any symptoms of pelvic condition, wouldn't it be also a normal part of an examination to say, since we're doing this, let's have a look? I mean, are there early signs that would be beneficial to know?
Yes and no. I mean, the symptoms, you have to kind of be paying attention to the symptoms and also just the timeline, the chronicity. If these symptoms are lasting for a long period of time, then that's something to be concerned about.
Gotcha.
But with respect to age, most of the women that present with pelvic congestion syndrome are not elderly.
Yeah, that's what that's what I was going to ask you, because we talked about how insidious of a disease venous insufficiency is, and the older we get, the more likely we are to have some, and the older we get after that, the more likely it is to be serious. So I'm guessing that the female body gets a head start on all this discomfort because of this pelvic area.
Mm-hmm. Yeah, most patients present more during the ages of 20 to 45.
Gotcha.
And in most women who develop this have had several pregnancies.
Mm-hmm.
It's typically not just after one pregnancy, because pregnancies do sort of push the process along. But what is the process? Well, again, it's very, very similar to venous insufficiency of the legs.
Okay.
Veins carry blood back to the heart, no matter where we're talking about. Whether it's your legs, whether it's your arms, whether it's your head, or even or your internal organs.
Sure.
The internal organs have arterial blood supply in and vein supply out, just like everywhere else.
Let's take a little detour for a minute here, because I think that's kind of significant. Obviously, one wants to know, all right, it seems like all of these parts in your body, they're very important. And so they have to have their own blood flow. They're not second citizens. They get their own. So that means that literally within the venous system, there are many other systems. You're talking about dozens, maybe.
Yeah, absolutely. Yeah. You're right. Each individual organ system. There's no second citizen.
Yeah.
Everybody has adequate blood in, hopefully adequate blood out. But problems arise when there's inadequate blood flow in either direction. But in this situation, it has to do with the veins taking blood out of that part of the pelvis and those organs. So, so the normal blood flow within the veins in the pelvis should be going upward, back to the heart.
Sure, yeah.
And the way that also, similar to the legs, the way that those valves function to accomplish that is by having one-way valves in them, and those valves can fail. Just like in the legs.
Yeah, I was going to say it must be just like the veins in your legs, right?
Exactly,
the
like
valves, I should say.
Exactly. And typically it has to do with dilatation of those veins, especially in this syndrome, and that's where we kind of get back to pregnancy. During pregnancy, the blood volume in a lady's vascular system increases tremendously. It increases by about 50%.
Wow!
So that's a large volume.
Well, like I said, I think in a previous program, we have to give our hats off to these ladies that have multiple babies, because us guys, I don't think we have any idea of the reorganization that your body goes through each time you get pregnant and have a child.
No, it's amazing. It's amazing.
It really is.
And especially this part of your body.
Yeah. But, one question that begs to be answered in this is that obviously, there's a certain percentage of people that are going to get this and a certain percentage of people that are not. And I'm guessing that prior to the treatment that you're able to provide now, what did people do to treat that before the modern stuff that we talk about, the insertion of the little wires and all of that kind of stuff that we're going to talk about here down the road? How did they treat this in the past?
They probably didn't treat it adequately.
I was going to say, maybe not adequately.
Yeah. And again, getting back to the diagnostic modalities that we have now that we didn't have 20, 30 years ago, the diagnosis, I think, was very evasive for a long, long time. And certainly the interventional things that we're doing nowadays, they were non-existent 30 years ago. So unfortunately, there were many, many women that just kind of had to put up with it.
I'm guessing that the OBGYNs are so happy that there is a professional, another doctor that can take care of that issue, because obviously most of them, it's not that they couldn't maybe learn how to do it, but they're so busy doing the basic functions of how's the body, how's the kid. When there's another, it's not just a sore back. You keep saying your back is sore. We need to have you looked at. It might be something else.
Yeah, absolutely. Yeah. And the surgical or the interventional remedies for this are outside of the scope of the primary practitioner keep taking care of these ladies. who are, coming to their offices and saying, hey, listen, I've got this abdominal and pelvic pain. I don't know what it's from, but it's really incapacitating me, and my quality of life is terrible.
I've actually seen a couple of commercials lately. We've talked about this on other programs, and I'm sure all of you that are out there. By the way, if you just joined us and you wonder, who are these people? Who are they talking about? I'm Mike Buck, of course, and Dr. Randall Julep is the medical director of the Vein Clinics of Hawaii. 4 islands, 4 clinics, lots and lots of stuff going on. And what I'm saying is that, when we look at this stuff and we look at the treatment and we look at all of these diagnostic things that are available now, it's just kind of a miracle that we got through it in this case without that. And particularly with this, I mean, it looks to me as though you have to be able to really diagnose this properly and then map out a treatment plan. So let's get that as part of what we're going to do. I guess that's going to be, what is the process?
What is the process of intervention?
Yeah. Once you've determined that, yes, we do have, a problem here, it's pelvic congestion syndrome. Here's what it is, ma'am, and here's what we can do, and let's talk about how we want to get this treated for you.
I'd like to say a few more words about, symptoms, because, again, it's such an elusive type problem, and there's so many, I think, women out there that probably have this that don't know it. Mm-hmm. That I think it's worth kind of mentioning some of these things, just so it might click in many ladies' minds.
Make a list here of what you think you might be a part of, and don't self-diagnose. I mean, self-treat, but certainly learn how to differentiate irritation of any kind, pain, itchiness, throbbing, achy, all of these things in the pelvic area.
Mm-hmm. Yeah. Right. So, we mentioned that pain is the main symptom. Yeah. But you can, if you pay attention to the quality of the pain, that can give you a few clues. For instance, and this is also similar to venous insufficiency and varicose veins in the legs, and that is that it tends to get worse over the course of a day. As you're standing,
sure,
in an upright position, again, because as you're standing, all of that blood is, falling down into the pelvic organs, and that's what creates the congestion and the pain. Now, the one other good sign of the fact that this might be the problem is that when you lay down, when a lady with this pelvic pain syndrome lies down, it decompresses all of that venous flow downward in the wrong direction.
Gotcha. I was going to ask that because we all know some of the things we talk about on the program, and some of the things that you can go to veinclinicsofhawaii.com and look into this yourself. We talk about elevating legs, we talk about support hose and everything else, but none of those things seem to be available for this particular area, the pelvic. You can't put a compression sock on it.
No.
You elevate your legs, and it looks to me like you're making flow and stuff in that direction, but elevation probably does help a little bit.
Yeah, well, when your body is reclining, it'll decompress that. But probably elevating the legs is going to benefit this process too a little bit because it's all kind of connected. Yeah. But so that's another important clue. Like we mentioned, it's usually in what we call multiparous women. That means women that have had more than one child.
More than one child.
2, 3, 4 pregnancies. And they can also have, aside from the pain and the other things that we've already mentioned, it can actually cause more, constitutional kind of symptoms too, generalized symptoms like just lethargy, depression, swollen pelvic areas superficially, lumbosacral neuropathy.
I know what that means. Lumbo what?
Lumbosacral neuropathy, getting back to the back pain part of it. Yeah. Rectal discomfort, urinary frequency, if you're going to the bathroom more than you normally do. So, a lot of things can point to this, and I think it's worthwhile to kind of keep it in mind, especially if you're starting out with abdominal or pelvic pain and you're trying to figure out what it is.
Okay, here's another thing. I started to think about this a while ago. I think that we're seeing way more television than we ever seen about medicine. Pills, what's it going to do, and I find that the questions that we're addressing today, which you would have never seen on television before, does it hurt to have sex? Does it hurt to urinate? Does it hurt to have a bowel movement? And this lady says, well, yes. And so I think that maybe women and men, everybody is more be more willing to say, hey, wait a minute, that's kind of me too. Isn't that why those commercials are probably framed that way?
Well, yeah, and that's why they're worthwhile.
Yeah, I think so too.
Even though they can be a little silly sometimes. But yeah, at least, as the years go by, we're, as a society, more open to talking about all this stuff, which is good because, communicating about these situations and symptoms gives everybody the opportunity for that light bulb to go off. In their
and you know what? Whatever it takes. That's why you can go to the website, veinclinicsofhawaii.com, and you're going to be able to see some of the pictures, some of the things we're talking about. You're going to see some of the conditions, and coming real soon to the website near you are some of these shows. We're going to get these shows so you can click on pelvic congestion syndrome and learn, or any other of our program. So I think that this is kind of fascinating. Once again, I want to give credit to the medicines that have been developed, but a lot of those are pill-looking things. And I've asked you on previous programs, is venous insufficiency treatable by oral medications? And I guess there are some that help, but do any treat?
There are probably a couple that might help the symptoms a little bit.
The symptoms.
Yeah. But it's not, again, since it's a mechanical problem, as is pelvic congestion syndrome.
Okay.
That's a mechanical problem with the, valve failure within the veins. And, since it's a mechanical problem, a medication typically is not going to fix that. So you're kind of left with interventional modalities to reverse it,
That's what I think is fascinating, because I think that now almost all of us want a pill for everything. I mean, if you take a look at the research being done in Alzheimer's and in AIDS and in lots and lots of things, everybody's working on medication, which is great. But it doesn't seem, because this part of your body that we're talking about and your specialty is, it's like a motor. I mean, there's things moving around in there. It's a machine.
Right. Right. Yeah. And that's what has made, being in this field so rewarding, because
I bet. Yeah.
a lot of these treatment modalities that we have now are relatively new. We didn't have them 20 years ago. And it's fun. It's fun watching it progress and evolve.
Yeah. I'm guessing another thing, and you mentioned earlier that sometimes one of the symptoms might be depression or lethargy and all of this stuff. And I think maybe a partner will recognize that and say, you haven't been yourself lately. Are you feeling okay? And maybe guys, you ought to do this, or whoever. I mean, maybe you ought to say to somebody, you're taking pills for depression. Maybe it's not depression.
Yeah, well, maybe there's another reason.
Yeah,
sure.
Yeah.
I think along that point, the symptoms of pelvic congestion syndrome, just like the symptoms of venous insufficiency of the legs, they come on over a relatively longish period of time and in a fairly slow fashion. So sometimes people aren't really recognizing them. And as we've talked about before, sometimes it takes a spouse or a family member to say, hey, did you know that this is going on, and is that a problem, and should you do something about it? Yeah,
and by the way, that's another reason to listen, because some of you may be just about to go away. Don't, because there might be somebody in your family, in your extended family, in your church, in your club, in your neighborhood that you notice have displaying some of these symptoms, or maybe they are always talking about that. Sometimes I think talking about a symptom helps a little bit. You don't want everybody to think, what's so angry? Oh, I've got this horrible headache. Well, at least you know that something's going on, right? So I'm thinking that, like you said, and it might be the dawn of a new age, we're willing to speak about things openly. We're talking about, pain during urination for a woman and pain during sex. We wouldn't have talked about that 10 years ago.
No, probably not. Yeah. Probably
and I think that that's part of the whole attitude of, all right, since it took so long to develop in the varicose veins, you're saying that this also takes a while. So is the turnaround or the cure a lengthy one?
Not necessarily.
Yeah, that's good.
No. Yeah. I think the crux of this problem is getting to the diagnosis.
Sure.
Making the diagnosis, figuring out that this is what the problem is. And then once you do that, it's, a relatively easy fix. Now, it's an interventional kind of thing, but it's a relatively easy fix. So that kind of begs the question, how do you evaluate somebody with pelvic pain? And like I mentioned before, typically the first thing that we do for abdominal/pelvic pain is an ultrasound,
right,
because it's non-invasive. It gives a fair amount of information. it may not make the diagnosis. But in this case, it usually doesn't make the diagnosis, but it rules out a lot of other things.
Yeah. By the way, I noticed at the clinic, at one of the clinic here on Oahu, when you fill out a questionnaire, it's you do this on a scale of 1 to 10. What does this feel like, or what does that do? So I'm guessing if somebody, and look, I'm imagining that there are a lot of women, Doc, that are strong like a lot of strong men, and some of them can put up with a lot of pain, and some of them can't. And so I'm wondering, at what point in time does it feel to the touch sore? Can it get so advanced that even touching that area or rubbing that area would cause the pain?
I suppose it could, but typically it doesn't.
Okay.
You may have with deeper palpation of the lower abdomen. Would you have a little tenderness? Yeah, you might, but it's more of an internal, chronic, throbby kind of pain.
Yeah, not like the overnight the cramps in the legs and the aching and the throbbing and the beating.
Right.
Yeah, that's good. Okay, so but however, it seems also that it could unlock a lot of keys to happiness. Once this thing gets diagnosed, you can have some pretty good days and pretty good things.
Oh yeah. Like I said before, these symptoms can be tremendously debilitating over a long period of time, definitely affecting your quality of life. But usually we do an ultrasound. And typically, again, for pelvic congestion syndrome, the ultrasound will most likely be negative with respect to that diagnosis. Now, it's going to show that you don't have gallstones. It's going to show that you don't have an ovarian cyst, which are all important things to know. But it's not going to make the diagnosis. Then often the next step might be a CT scan.
Okay. And for those that don't know exactly what a CT scan is, what is it?
Well, that's a little higher, technological kind of test that we do that actually shows sort of cross-sectional views.
So this is like what they call a CAT scan? CT scan?
I'm sorry, CAT scan. Yeah, CAT scan. So, we do a CAT scan. That gives you a much better view of what's going on. But that also, unless it's done in a very particular way, may not and possibly won't make the diagnosis of pelvic congestion syndrome. Now, so what's the next thing that happens? Well, it depends on what kind of physician you might be going to, but a lot of women in the past have gotten what is called laparoscopy.
Laparoscopy.
Now, laparoscopy is a scope that is put through the abdominal wall, and you can actually look inside the abdomen.
Wow. Yeah.
And that's a test that, in order to do, you have to sort of inflate the inside of the abdomen.
I was going to ask that. How do you accomplish that?
Yeah, you stick a little needle into the abdominal cavity, shoot a bunch of CO2 is actually
like air. I mean, gas, I should say.
Gas, yeah, that's the gas that is shot into the abdominal cavity. Makes everything kind of move out of the way so that you can then put a bigger scope in.
Wow.
And you can look around. Now, the problem is with respect to making the diagnosis of pelvic congestion syndrome is that inflation of the abdominal cavity then makes all those veins just, decompress.
I was going to say, that's a big relief at that moment, at least for those veins. So would they slip by the test as a result of that? Oh,
yeah,
okay.
So very commonly, laparoscopy also is not going to make the diagnosis.
Wow, yeah.
So anyway, probably the gold standard. Well, the gold standard is venogram. Doing an actual angiogram of the veins. But
wait. What does that entail?
Well, before we get there, probably the best test, the best non-invasive test would be an MR venogram, sort of like an MRI.
Like an MRI, but it's for
it's for the veins because we shoot contrast into the vasculature and we can actually see those veins.
You watch it moving, right?
Yeah. And so that's a pretty reliable test and a fairly sensitive test to make the diagnosis of pelvic congestion syndrome. We like to do that before we then move on to a more invasive kind of procedure like venography.
Yeah, that's what I was thinking, and I had once this horrific injection where they put something in your foot to make it go uphill. And I guess that this is a way less invasive way of doing that test.
It is. Yeah. So you had a venogram.
I did.
Yeah. So, So
only one. I said, hey, you know what? I'll lose a leg before I do that again.
Yeah.
But I'm kidding. It was pretty sore.
Yeah. The type of venogram that you had, can be very, very uncomfortable. Yeah. Fortunately, the type of venogram that we would do to look at pelvic congestion syndrome is a lot less uncomfortable. Very, very little pain
Which is
involved.
With everything, gang. The reason I keep bringing this up because I'm like a kid in a candy store to give you the information you need. A lot of the technical stuff that we're talking about, you have to go to www. Vein Clinics of Hawaii to get that stuff. But I'm saying I get so excited when I find out how things are different. Many of us, me included, if you've been listening to the program, I'm not just a host. I'm a patient. Venous conditions ran in my family. It's hereditary. I've got vein issues of my own that I've been having very, very nicely treated for a number of years. In really impressive in increasing my ability to enjoy stuff. However, I remember in the very beginning when I found out about this, right out of college and football, when I had these vein issues. My mom had been in the hospital a couple of times for like 10 days or a week, and then coming home and being miserable. And I thought, geez, I'm just not going to do that. I'm strong. I'm a bull. Now, men that used to think that way, they don't have to even think about it because women aren't going through that anymore either. I mean, I knew you do, in some cases still, I know, do that big leg stripping, but very infrequently, right?
Yeah, very uncommonly. Yeah. Hardly ever.
Yeah,
hardly ever.
So there you go. So that's why I get excited. And so that means that if one by one you get this, like if you've done the venogram, the MRI for the veins, that must be a real eye opener. Open it up and say, bingo, this is what we've got here.
Right, right. So and that's just it. Those two modalities can make the diagnosis, and then you can map out a plan for treatment.
Mm-hmm.
And often with the venogram, you can do that right at the same time.
I was going to ask that. Aren't some procedures able to take place while you're looking for things?
Yes. Yeah, especially, angiography.
Yeah, since I'm in there, let's fix it.
Well, yeah. Definitely. Since it's an invasive kind of procedure, if you can eliminate it doing a second time to bring about the final treatment, all the better. But, there have been other things tried, before we get into the venographic kind of aspect of it and the treatment involved there. There have been other treatment modalities for this procedure, for this syndrome that have been tried in the past. There have been medications. Mm-hmm. Usually it has to do with hormonal manipulation. Okay, so hormones have been tried. But the result has been less than optimal. Many women in the past may have undergone a hysterectomy. Mm-hmm. You're getting rid of the uterus, which is the kind of the organ involved in this
the host of all of this stuff, right?
Right, the main host. Yeah. But you're not. If you do that, you're still not getting rid of the main problem, which is the veins. The veins are the problem.
Yeah, at the end of the veins, the stuff that used to be there is gone, but the veins are still there, giving you an issue.
Right, right. So, none of those things were really optimal, and they may have women may have had a little bit of relief from their symptoms, or maybe a fair amount of relief, but then the pain comes back. So I think the search continued to find something that really was going to fix the problem.
Okay, and I'm guessing that some of you out there that are listening to the program need to know more, and you can do this. We're giving you the big. Pelvic congestion syndrome 101, the big picture. But if you actually have said, gee, I've got that, and gee, I've got that, and yes, I did this, and yes, I did that, it might be a time for you to say, how many of these symptoms have you been just putting up with because they come with age, or they come with the shape I'm in, or they come with this and that? And if you could eliminate half of them, what would it do to the way you get around and enjoy yourself?
Yeah. Oh, yeah.
That's what this is all about.
Right. Yeah. Quality of life. Quality of life. Pelvic congestion syndrome is not a fatal problem. It's not going to kill you, but it can really mess up your life.
You up, you die little by little. But I think that, none of this is visual. To me, I'm learning about this syndrome. I'm sure there's some things that you as a doctor would say, I think that this is based on that right there. I think we got to take a look at this. But I'm thinking that the families, that the husbands and the wives, they don't. There's nothing that screams out and says, "Gee, what is this?"
Yeah. Right. In a kind of going back to venous insufficiency of the legs.
Yeah.
There's plenty of major symptoms.
Yeah, and you see them too.
But sometimes you don't.
Mm-hmm.
Sometimes people with a tremendous venous insufficiency in their legs don't have varicose veins.
Dang. First time I heard that.
Yeah. So that can be a little more of a problem in diagnosis, just as this can be getting to your point of you can't see anything.
It looks to me, what you've talked about so far, and thank goodness, there are a number of roads that you can do professionally to determine what's going on here. It's not just one test. It can be, if at first you don't succeed, let's try this.
Well, and I think the point there is that, a lot of different things are tried, because when a woman comes in with pelvic pain, it's a pretty generalized kind of complaint, and you don't know which direction to go. Is it is it a bladder problem? Is it a ovarian cyst? Is it endometriosis? There's a lot of women out there with endometriosis, and that can create the same sort of pain. So you don't know. It's you're on a fishing expedition, but and part of it is ruling out all of those things that it's not often, until you finally get to the test that needs to be done to nail it down.
If you have done the test that you need to do, and you find this lady to have pelvic congestion syndrome, with a lot of the things, there are things that you can do to help that. I mean, we've talked about it before a lot. We're going to talk about it forever. You have comorbidities or things going on in your body, diabetes, hypertension, edema, phlebitis, all of these other things that may or may not be only veins. That there's got to be, when you discover this, that there's some immediate victories, that there's some relief almost immediately, depending on what the treatment is that you're going to talk about.
Sure. Yeah. Well, as soon as you can define it, then you can conquer it, or come up with a plan to make it a whole lot better. But yeah, so typically, the final test that we need to do is a venogram, and I think most people have heard of having a heart catheterization, where
more and more. There's just a piece the other day, and you can Google this. There's a lot of information out there.
Yeah. A tiny little tube is put up through the groin artery. Sometimes they are, or many times now, even going through the wrist, to look at the circulation to the heart. So I think a lot of people had either had that or had family members that have gone through that. So there's I think a good picture of that people can have. Well, the venogram that we do for this procedure is very, very similar to that. We go through the groin, but we don't go into an artery. We go into a big vein.
A vein instead of the artery, sure.
Because we want to, it's the venous system we want to get to. And then we thread that catheter up to where those veins start, and like we were saying before,
they're high up the pelvis.
Well, they're actually in the
the abdomen.
Mid abdomen, which the main culprit is usually veins that come from the mid part of the abdomen, from much bigger veins, and then go down, travel through the lower abdomen into the pelvis to the ovaries and uterus. And again, those are the veins that are not working. The blood is going in the wrong direction. So we thread that catheter up into those veins that are going downward to the ovaries, and you can inject dye. That's what
so actually,
we do.
If you can see this in your mind's eye, because Dr. Juliff gave me something that I visualize this. This thing that he's talking about goes up and then down. It climbs up and then is able to be guided down to where the vein that needs to be treated.
Correct. Yeah. Wow. So we shoot dye into those veins, and then you can actually see the blood going in the wrong direction. It's settling downward into the pelvis and just kind of settles down there, as opposed to moving up, which is the way it should.
Okay, I got it. Now, what do you do for it?
Well, The procedure that we do is, again, very, very similar to the procedure that we do in the legs, although it's done in a very different fashion.
Sure.
But when we have bad veins in the legs, with the when we're treating the veins that we are able to in a routine sort of fashion, if the vein is not functioning properly, then we close the vein down.
Gotcha.
Now, as we've talked about before, typically we close it down. There's a number of different ways you can close veins down, but in the legs, most often it's either with a laser fiber or a radio frequency catheter that heat up the inside of the vein and close the vein down. We cauterize the vein from the inside. Okay, well, that doesn't work as well in the pelvis.
I was going to ask that. And obviously, when we're talking about this, not to be a fearmonger, this is happening under a very controlled surgical procedure in office. It's not a house of pain. It's not, and you don't have to say, I got to get strong, give me a popsicle stick to bite down on. That's just not going to happen that way.
No, it's pretty pain-free.
Yeah. As a matter of fact, throughout the process, one of the assistants is saying, "How you doing? How you feeling? How's everything?" And because you can tell a lot when somebody manifests, right?
Oh yeah,
a little pain. Whoops, got to look at that thing. What's that?
Right, right. Yeah. So we make the diagnosis by shooting dye in those veins, and right then and there, as we mentioned before, we can actually treat those veins. Now, we also the goal of that procedure is to close those veins down, also just like we do in the legs.
Otherwise, it's going to be a problem right back again.
Otherwise, you can do other things. You can take out the uterus. You can do a number of different things. But if the veins are there and they're not functioning properly, then the problem is going to continue. So we close those veins down by injecting various materials into the veins that are going to basically cause those veins to clot off so that the blood flow ceases. And so we're eliminating that abnormal flow.
Now, this is a good thing. This is what we're trying to do. In every program, we talk about this in one variation or another. And I think that because we're talking in sort of a semi-clinical way, that you have to know the speed in which this happens. Because what you're talking about when you're treating this, it's instant. I mean, basically, but then I would imagine once you have, shut these veins all off, there's going to be a period of time where they're going to, assume a new role, and the symptoms will have disappeared by then.
Yeah. Well, you're right. We see it we see it immediately. Now, the procedure takes a little bit of time, but by the end of the procedure, when we do another venogram, when we, introduce more dye into those veins, we can see that there is no longer blood going in the wrong direction. So it's a pretty instantaneous fix, and the radiologic success. Now, the radiologic success is not always symptomatic success, but the radiologic success of these procedures is pretty high. It's around 99%.
That's amazing, isn't it?
Yeah. So
it is high.
So rarely are the veins that are the culprit problem not handled in the way that we want them to be handled.
When you talk about somebody that's on chemotherapy or somebody that's on radiation treatment and some of these other things, I'm not guessing that most of those things were part of a regular venous, treatment at all. But there would be some that would maybe scare people until they found out what version of it was or what variation it was.
Mm-hmm. Sure.
And so we talk about, we're fixing this thing, but what about, and I know that this comes up in our frequently asked questions, what are side effects? I mean, obviously you're going to treat the vein, and so the symptom that was causing that issue, but are there side effects to some of this stuff?
There can be. I think the main drawback is lack of response, but luckily it's pretty low. I think that, it's about an 80-85% substantial improvement in symptoms.
Way better than Vegas odds. I mean,
way better. So, as far as a vascular negative repercussion, no, there isn't. And we get asked that question all the time, especially in the legs. They say, "Doc, if you close these veins down, am I going to be okay? Is my leg going to fall off? Or
Every time we talk about this, and the logical thinking is, okay, you got 26 teeth most of the time. If you start pulling them off, you don't have any more teeth. But you can get implants and you can get things. Well, you don't need to do that with your veins, because that system, don't know what the miracle is. The minute you find out that you can give it to me in English that I can understand, I want to know. But the bottom line is that body says, oops, the blood that we used to put over there is not getting where it needs to be. We're going to go another way.
Right. Yeah, the wonderful thing about the venous system is that there's a tremendous amount of redundancy. Yeah. And just like you just said, if the blood can't go in one direction, then it'll get to where it needs to go in another. And that's what happens in this case. We close those veins down. Again, these are veins that aren't working anyway. They're working against you. And even though we close those veins down, it's good because we eliminate that abnormal flow of that blood and pressure going into the pelvis. But the blood finds another way. There are always other avenues. It's
really magic. One of the things that differentiates between an artery and a vein that you've heard on the program many times is that the artery is taking this big thing up in the top of your chest called the heart is pumping this blood that it gets back from the lungs and back from the filtration, and it's blowing it right through the body. And there's no valves. It just goes. But with the veins, there's different. What about down the road? I know that people are, I saw a paper on this one time. There are actually people working on trying to make a valve.
There are.
And would that be the game changer?
It would be a tremendous game changer. Yeah. Now, not this scenario would be even more difficult, but there's a tremendous amount of work being done on artificial valves and or repairing valves of the veins in the legs, and unfortunately, we just have not come up with a real consistently reliable, low morbidity kind of procedure, but that's being worked on.
I would say
at some point it will.
Yeah, hang in there. But in the meantime, the good news is that the treatment that we've talked about here, and even though we're talking about something that sounds like, oh my goodness, is that going to hurt? Rarely does a patient not walk out of there the same day that they walked in, a few hours later, and go home, maybe take care of something for a half a day, and then just get back to normal. That's. I think that is unique in any treatment. Yeah, maybe it takes a long time for this condition to come along, but once you've treated it, boom, you're off the hook for that vein because it's not going to be a problem ever again. Especially for the leg procedures that we do. I mean, people literally they're in the office for an hour and they leave and go on with their day. This procedure that we're describing may be a little more downtime, but still, I mean, it's not it's not like you're laid up in the hospital for a week and a half. Okay, but what about some of the people that say, well, do we automatically, the minute this comes through, boom, are we going to have surgery? What are some of the things that would indicate maybe it's you can wait a little while or this is more serious? Are there degrees of this syndrome, this pelvic congestion syndrome, that really dictate you need treatment like immediately, or you ought to look at this down the road, or maybe in a year? Yeah, there are. And, we go primarily by symptoms, because this all of these things that we do, even though they are minimally invasive, they're still invasive. Yeah. And anytime we do any kind of invasive type procedure, there are risks involved. And now for most of the procedures that we do, the risks are pretty low. Yeah, I was going to say, still, that's what I've come to learn. Yeah, the overall risks are low. What would indicate a follow-up? I mean, let's say that you do surgery on Sally today for pelvic congestion syndrome. Follow-up? Sure. Yeah? Yeah. I mean, that type of patient is going to be following up not only with us, but also with their gynecologist and their PCP, everybody. Sure. But we wouldn't follow this kind of patient radiographically necessarily unless they were having recurrent symptoms. The same way that we do with leg veins, we tend to monitor them pretty closely. Sometimes, and it's not because of our vanity, but in some cases it is. We look at spider veins. We don't want them. We're going to go to the beach. You don't want somebody to see varicose veins. I think that what happens in this one is it's symptom-driven, not appearance-driven, and maybe that gets people to think it's not as serious because they can't see anything.
Right. Well, I guess when you can't see stuff, it's a little easier.
Out of sight, out of mind, right?
But at some point it does. At some point it becomes very significant, especially with the patient. And I think the getting back to who, when do you decide to intervene on somebody? It really is based on their symptoms. Is that patient having enough of a detrimental effect from this syndrome to warrant undergoing an invasive procedure? I mean, you always have to weigh risks against benefits. And for the most part, we have to let the patient tell us that.
Yeah, let me tell you why I came up with that question, because I've also seen more in-your-face adult diapers and Depends and really improvements made in some of these garments. And sometimes they just say, well, I have a weak bladder. So, I mean, and yet it's also painful. That's a sign. I mean, you can have the pants so that you don't wet the bed and you wet yourself at work, but you're not doing anything to fix this thing. All you're doing is controlling it.
Yeah, it may be just a Band-Aid.
Yeah. But that being said, it must be that some people think, well, okay, it's better than it was, but why is it still happening? And wouldn't that be a trip to the doc? And the doc might say, well, here's a number of things, and oh, by the way, you have a couple of symptoms that might be a reason for me to send you to somebody to have ultrasound and find out what's going on in your pelvic area.
Sure, yeah.
That's it. I'll say so. But one of the things that you've been asked on other shows, and we talk about a lot, is the relative certainty that particular vein was never going to be a problem again. What about chronic pelvic congestion syndrome? Is that something that happens to some people? They get treated, and there's no more visible signs of this, and then a year later they're back in with more problems.
That could happen.
Yeah.
That can happen. Just like in the legs, which is why we tend to monitor these people. But again, I think with pelvic congestion syndrome, we're going to base further evaluation primarily on symptoms of the patient. If they have return of their symptoms, then they require a reevaluation. Maybe there's another vein that has become incompetent and is leading to the same sort of process.
What about when you talk with staff, when somebody comes in for a new treatment or a shaving haircut or just a check me up on me, and they report things, and I'm sure it gets to you as well, but before I had this, I had that, and boy, oh boy, I couldn't do this, I couldn't do that, and now I get this just a little tiny symptom. I want to get it fixed because things have changed. Isn't that why? I've been in your offices. Your people are happy people, because what happens is people come in there and they get results. And isn't that the whole thing about this?
Oh yeah.
Not
definitely.
just take these pills.
Right.
Yeah.
Which is again, has been one of the great things about treating people with venous insufficiency, because number one, they come in and they want to be treated. They've got a problem that they recognize and want to have evaluated and taken care of. And by and large, most of our patients do very well. They come in with symptoms. We do, the evaluation. We figure out what they need. We do it, and they feel immediate benefit.
Okay, so we'll come full circle here. And what we originally told you when we first started the program, Dr. Julep and I did a show, and we're going to do many of these that are just frequently asked questions. And one of them was this pelvic congestion syndrome. And I thought, okay, let's talk about this. So now first of all, it's a little bit more common than I thought. There are, percentage-wise, 30% of women who suffer from this pain for one reason or another. It changes their life. It deadens their part of their life.
Yeah,
and getting at this is just a miracle on ice, really.
Yeah.
Okay, so if you or your loved one or anybody is experiencing any of the stuff that we've been talking about, it's time to pull the trigger and get on to veinclinicsofhawaii.com and go click it, make an appointment. You can do that, by the way, from the website on any island, on Maui, on Kauai, on the Big Island, and here on Oahu. And that's because there's clinics on all of that, bricks and mortars for you. And I hope you've learned something, and please tell people about us, and we'll be back again next week with another one. But now of course, we can't say I know everything now about pelvic congestion syndrome, but I know enough about it to say, women, thank you for what you do, because that's a condition that none of us guys want to ever go through, right?
Right.
Okay, so we'll see you next time. Thanks for being a part of the show. And like I said, tell everybody about Vein Clinics of Hawaii. All right? See you next time.
Well, that's our program for today, and we certainly hope you enjoyed meeting us. Please come back next week for our next episode. And in the meanwhile, to learn more, please visit our interactive website, veinclinicsofhawaii.com. That's veinclinicsofhawaii.com.